guys, welcome to the second presentation, Monthly Education Committees. Can you start over? Now I'm getting on. Hey guys, welcome to the second presentation of the Education Committee's educational videos. This is number 2. Last month, for the month of July, we did malignant hyperthermia, which is very rare. And all of these monthly presentations, hopefully we'll be presenting on our Skills Day at some time this year, the date to be announced later, at a later date. So anyway, today we're going to do airway management and laryngospasm, which is something that's the highest focus in the PACU, something that we need to be very familiar with as peri-anesthesia nurses. So we've gotten Dr. Mark Singleton is going to come in and speak with us about these issues. Rhonda Erskine is going to come in and assist him, and hopefully we learn a lot. Here you go.
Thank you. Rhonda and I will talk a little bit about what we encounter sometimes in the post-operative period, and also often in the operating room. I'm going to talk a little bit about anatomy of the patient's airway and also about the equipment that we use. So we have a breathing circuit here. It's attached to the wall oxygen, and we have masks that are appropriate size for patients. When these masks first come out of the packaging, they're a lot like the bicycle you haven't ridden for the past year, and the tire is pretty flat on these. If you ever need to use these to break a laryngospastic event or provide positive pressure ventilation to a patient by mask, you really want this cushion on the mask to be very tight. That allows you to get a good seal around the patient's nose and mouth. So these masks come equipped, except for the very smallest infant sizes, and there are some ways that you can actually inject air into even those with a very fine needle, and the air will stay in the cushion. I do that for neonates when I'm involved in resuscitation. One of the first things I always do is inflate these one-way valves with air, which you can do with a syringe. Some masks actually come with a valve that can be blown into by mouth if you don't have a syringe handy. Also, these come out of the package with this little device. It's a 4-pronged ring that is associated with the mask. That is for the sole purpose of providing a head strap, which goes around the patient's head and attaches to these 4 prongs and helps to hold the mask when you're doing other things with your hands or can't actually hold the mask. These aren't used very much anymore. Laryngeal mask airways have pretty much taken the place of mask and head strap ventilation. So this breathing circuit is commonly known as a Jackson-Reese breathing circuit. It's named after an old anesthesiologist who invented some of these devices. The elements are a one-way flow of oxygen into the breathing circuit, and its egress is into this reservoir bag. Sometimes the reservoir bag has a valve at this end that allows you to create variable resistance so that you can have this bag inflate but not overinflate as you ventilate the patient. This particular model design has a relief valve that allows variable resistance to be applied here, and there's a spring-loaded pressure gauge. But really the best way to adjust the pressure is to do it by feel with your hand to see, how much pressure you're providing to the patient. So if we turn this on and we have a good fit here, this bag should, it's probably going out the mannequin's mouth, but you can see that just by holding my hand over the end of this, I'm able to get pressure to develop inside that. Now it's closed and I get lots of pressure. You can see that valve increasing. The difference between this device and an ambu bag is important to know. Ambu bags were designed to allow ventilation of a patient by someone who's unfamiliar with or inexperienced at airway management. And the elements that are involved in an ambu bag that differ from this are a self-inflating bag so that every time you squeeze, the elastic recoil in the design reinflates the bag. It also draws ambient air in that process, so you're never able to deliver 100% oxygen with an ambu bag because ambient air is being drawn into the bag in that self-inflating process. The higher the flow rate you put into an ambu bag, the more oxygen will be present in the delivered breath. With this design, it is essentially always filling with 100% oxygen. So that's the difference there.
Now, how do you hold it onto the patient's face? Can you demonstrate how you would apply the Jackson Weiss mask?
Anesthesiologists are taught to always hold the mask on the patient's face with the left hand. The palm, this part of the palm of your hand is meant to sweep the patient's cheek up to the mask, and these two fingers generally hold the mask over the bridge of the nose, the chin, and apply a seal to the right side of the face. I always tell residents and students when they're learning to do this, it's a little bit of a misnomer to say we're putting a mask on a patient's face. What we're actually doing in this process is drawing the patient's face up to the mask. So we're pulling the patient's face to the mask. You want to be careful not to grab too much soft tissue and the tongue, because that can actually occlude the airway. You want to be really right on the mandible. One important point to realize is that the temporal mandibular joint we tend to think of as a hinge joint, like our finger, our wrist, or elbow, various other hinge joints, and it is that. When the patient's mouth opens and closes, we're using that hinge. But we take advantage of the other feature of the TMJ, and that is that it's a sliding joint. So this joint can actually move anteriorly and displace the tongue, which in a patient who is unresponsive, either anesthetized or for other reasons hypotonic,